Right, Dr. Kersh, you can introduce yourself and get started if you like.
So, my name is Sean Kersh. I'm one of the staff podiatrists here at the VA. A little bit about myself. I did my undergrad at the University of Texas in Arlington and went to medical school at Barry University. It's in Miami, Florida. And then came here and did my residency between the VA and the Health Science Center from 2007 to 2010. And I was hired on as staff back in September 2011. So kind of been around San Antonio for a while. And so I'm here today to talk about the aging foot and some of the pathology that's associated with it. And without any further ado, we'll go ahead and get started. So in defining age, it seems like in our society, 65 is now considered the magical age at which someone becomes officially quote-unquote old. However, old law is an arbitrary number. Age is just that. It just happens to be arbitrary. So in describing the aging foot, the foot in general, there are 26 bones, 33 joints, and more than 100 tendons and ligaments, everything working together almost in a pulley system of harmony, if you will. And by 65, most individuals would have walked over 75,000 miles. This comes out to roughly 3 times around the equator. Also, it's important to know that by the age of 65, most of these individuals have bore several million tons of weight on their feet just through progressive ambulation, particularly in hard surfaces such as concrete. Some of the common changes seen in the foot as people start to age, you will see an increase in foot size and width, mainly due to the development of bunions and hammer toes. It's also very common to see atrophy of the fat pad, particularly in the forefoot and also in the heel. Flattening of the arch, lowering of the arch, flat feet, also defined as pes planus, is very common. Ligaments and tendons over time become weaker. We also get tendon dysfunction as well. Xerosis or dry flaky skin. This is particularly seen in our diabetic population due to their autonomic neuropathy. And then thick and discolored toenails. This can be due secondarily to either trauma or nail fungus on mycosis. And also you'll have some patients that present that said their toes are starting to become crooked. This is just a predisposition to hammer toe syndrome. Some of the predisposing factors that cause these changes, diabetes, as we all know here, is a major player in all of this. Also arthritis, really osteoarthritis, rheumatoid, gout, even psoriatic arthritis, very, very common in the lower extremity. Osteoporosis, very common as people age. Peripheral neuropathy in conjunction with diabetes. Pes planus or flat feet. Pronation and supination of the foot. Pronation meaning lowering of the arch, where supination is the exact opposite of raising of the arch due to inversion of the foot. Obesity, morbid obesity, improper shoe styles that patients have worn throughout the years or even for decades, and also a history of any type of lower extremity trauma or foot injuries. So again, some of the common foot conditions, and all these we'll touch on a little bit later in the lecture, but bunions, hammer toes, hyperkeratotic lesions such as corns and calluses, generalized forefoot pain, also termed metatarsalgia, hallux limitus or hallux rigidus, adult-acquired flat foot, which is also known as posterior tibial tendon dysfunction, which I'll talk about a little bit later. And again, lowering of the arch or pronation, xerosis, dry and cracked skin, and then also the presence of nail fungus or onychomycosis. So, what about our population? So, it's important to note that by the year 2030, 1 in 4 patients, 25%, will be either 65 years of age or older. In addition to this, a third of these individuals will have diabetes, which is very significant. This basically means that there's going to be an increased prevalence of lower extremity pathology. So there's going to be a dire need for foot care in the immediate future. Lack of foot care, often leads to limited mobility as well as ambulation in this elderly population. That it can significantly impact their activities of daily living. And particularly in our high-risk patients, this neglect can lead to ulceration and subsequently amputation. When I say high-risk populations, this is mainly our diabetic population and also our vascularly impaired population that present with peripheral vascular disease. So what are some of the environmental and also physical issues that this particular patient population faces? There are four main ones: economic barriers, transportation, mobility, and isolation. Economically, a lot of these patients live on a fixed income, so it makes it very difficult for them to seek care, and also to obtain care. In addition to this, transportation is a major player as well. A lot of the elderly patients, they no longer drive or are incapable of driving, so it makes it very difficult for them to get to the hospital setting or the clinics in order to get the care that they need. Mobility as well. By the age of 75, 1 in 3 adults aren't as active or they're inactive. And also there's a high prevalence of arthritis in this population as well, again making it difficult to get to where they need to as far as routine checkups and exams. In addition to this, isolation. This population being older, they more often than not have a lack of adequate peer or family network, which impacts them socially as well as emotionally. So this really impacts the emotional aspect of healing, particularly if they have any type of large extremity pathology that's ongoing. So, where do we start? Well, I personally think that the diabetic foot is the best place to start, particularly here in San Antonio. So, this is a picture of the Texas Diabetes Institute, which a lot of internal medicine residents rotate there and even podiatry residents spend a great amount of time here as well. But it's noted that 18.3% or 8.6 million people in America age 60 or older have diabetes. In addition to this population, those that are over 65 years of age, there's an 18 to 20% prevalence of diabetes, and 40% of these people either have diabetes or they have the precursor to it that's known as impaired glucose tolerance. In the year 2000, diabetes was noted as being the 6th leading cause of death in the United States, and also it's noted as the 6th leading cause of death in individuals between the ages of 45 and 64 years of age. So that's very significant. As we all know, diabetes mellitus can cause chronic long-term damage, dysfunction, and failure to various organ systems in the body. And it's important to also note that there are more inpatient days that are spent treating lower extremity wounds than any other secondary complication due to diabetes. So a little about diabetic foot ulcers in general. In 1995-1996, Medicare beneficiaries were known to have an annual prevalence of 7%. Also, it's important to note that the cost of treating this particular pathology is 3 times higher than the average Medicare patient. And also 70% of these individuals have treatment with little or no follow-up. So that's very important. And Harrington discussed this back in 2000 in an issue of diabetes care. When it comes to the infected diabetic wound, more inpatient days are spent treating this particular type of problem than any other secondary complication from diabetes. And 20 to 25% of all diabetes-related hospital admissions are due to this particular type of pathology, which is huge. Lawrence Lavery back in 1997 wrote an article in the American Journal of Medicine in which he looked at the progression following a patient's first lower extremity amputation. And what he noticed was that there's a 68% incidence of a second amputation within a 5-year period, as well as there being a 50% 3-year mortality rate. And the interesting thing about this, though, is that 25%, 1/4 of these individuals after their first lower extremity amputation become institutionalized. They're unable to care for themselves. So that's a very striking figure, in my opinion. So what can we do as far as being healthcare professionals in order to do our part to treat this? Screening for high-risk patients is key. With high-risk patients, particularly that have diabetes, we're looking at individuals that have impaired protective sensation and also they're vascularly challenged. Those are the people that we need to see on a very frequent basis and make sure that everything's going okay with them from a lower extremity standpoint as well as systemically. Also, the development of educational programs and increased self-awareness, such as diabetes education programs and things of that nature. And also training more physicians and allied health personnel in evaluating and treating the lower extremity will go a long way as well. So some of the questions that we ask in podiatry when a patient comes in with an ulcer or we're screening for an ulcer, we ask first, is there a loss of protective sensation, which more often than not there is. In addition to this, we ask, is there an underlying or bony deformity that's the causation for this particular ulceration, and how do we go about addressing that? And the third question we ask is there a previous history of ulceration and or amputation? More often than not there is, and it's important to keep this in mind. So with peripheral neuropathy, there are a host of risk factors that are associated with it. It's commonly seen in individuals that have had a long duration of diabetes. Many research studies have shown that people that have diabetes over a 10-year period have some form of peripheral neuropathy. They may not have full-blown neuropathy where they can't feel their feet, but they have some type of impaired protective sensation. Also individuals that have highly controlled diabetes. The literature has shown that peripheral neuropathy is mainly associated in males as well as individuals that have advanced age. And also chronic alcohol use and chronic tobacco use can predispose someone to this particular pathology. Another common problem that we see in the elderly population and in the elderly foot is a vascular disease. And when you see this, it's important to get a good patient history. So some of the things that we ask about or we look at are this presence of any macrovascular disease, such as history of a prior stroke or prior heart attack, presence of any coronary artery disease or any heart pathology, presence of hypertension. All that is considered macrovascular disease. In addition to this, we find out about microvascular disease. Does the patient have a diagnosis of peripheral neuropathy? Do they have any diabetic nephropathy? Are they on dialysis? And also, do they have a history of retinopathy, any glaucoma or macular degeneration? We also look at something that's called functional microvascular disease, where that patient has a history of gastroparesis or any sexual dysfunction. If a patient has a combination of all three of these, more often than not, it's signs that are going to need a vascular consult, just because they're going to need some type of evaluation of their circulation, because at some point it's going to be impaired. And also asking about the family history is important as well, whether their mom or dad have a previous history of diabetes or peripheral vascular disease. And then social history, past medical history of tobacco abuse and things of that nature. So in a physical exam of patients that present with vascular disease, you know it's important to inspect the skin, make sure there are no open wounds or lesions. Also palpation of the pedal pulses. We mainly look at the dorsalis pedis, which runs along the dorsum of the foot between the first and second metatarsals, and also the posterior tibial artery, which is along the medial aspect of the ankle. We also look for pallor when there's elevation of the lower extremity, as well as louver when the limb is placed in dependency. These are signs of significant peripheral vascular disease as well. And in addition to this, we see if there's any change in the skin temperature gradient, particularly in comparing the foot to the lower leg, to see if there's any temperature change, which would indicate severe peripheral vascular disease. So some of the treatments for lower extremity complications, regular debridements, calluses and ulcers are key. Debridement of calluses will basically prevent ulcerations because calluses are precursors to ulcerations. And debridement of ulcers just helps in the wound healing process because it converts the wound into its inflammatory phase and causes the body to heal itself. Also, prompt treatment of cellulitis and underlying infection. More often than not, patients that present with chronic ulcerations will have to be admitted for anywhere from 24 to 72 hours if they present with a superficial skin infection or cellulitis. And this admission is mainly for IV, broad-spectrum IV antibiotic therapy. Redistributing the plantar pressures with appropriate shoe gear and custom insoles is vital. Also surgical correction of any underlying bony or flexible deformities, and limiting the motion of painful and inflamed joints is key as well. So a little about nail pathology. This is actually the most common foot complaint in the elderly. Some nail pathology that's associated with the aging foot consists of mycotic nails, nail fungus. You can also develop what are called pincher nails. This is where you get it's almost like an inverted U, the nail is shaped like an inverted U. Nail incurvation, dystrophic nails, classic ingrown nails, and then you can also have a subungual hematoma, which is secondary to trauma to either the nail plate or the underlying phalanx. So the most common cause for any type of nail pathology in the elderly is primarily neglect. And we see this quite a bit in our clinics, people that come in from nursing homes and things like that that haven't had a proper debridement or aren't receiving proper debridement. So some of the treatment for nail pathology, routine debridement of the nails is good, as well as treatment with antifungals. Clotrimazole is a very good antifungal, as well as Lamisil. And also when it comes to ingrown nails, they're very severe or they're recurrent, or if there's any sign of infection, a nail avulsion can be performed, as well as a chemical matrixectomy, removing the nail matrix so that the nail doesn't come back and the patient doesn't have to worry about any subsequent infections in the future. So a little about ingrown toenails. They're associated with an abnormal interaction between the nail plate and periungual tissues, the tissues around the nail. Pain and inflammation are associated with it, and there are a multitude of etiologies. It can be the normal anatomy of the nail itself, improper nail trimming, curving the nail borders instead of cutting straight across, the presence of a subungual exostosis, underlying bone spur underneath the nail, which causes incurvation, any type of trauma to the nail plate or to the underlying osseous phalanx, improper ill-fitting shoe gear, and biomechanical dysfunctions. It's been proven in the literature that actually people that have a lower arch foot are more prone to developing ingrown toenails, particularly along the medial nail border. And this is because of when you have a lower arch foot, you have increased pronation. So in the toe-off phase, you end up placing most of your pressure along the medial aspect of the nail, causing irritation. So some of the treatments for ingrown toenails, basic debridement of the nail border, again, a partial nail avulsion, completely removing that portion of the nail, matrixectomy, removal of the nail matrix in order to prevent the regrowth of the nail. And then the use of antibiotics, particularly in an infected ingrown nail. More often than not, we end up prescribing just a low-dose antibiotic such as Keflex, and a lot of patients respond really, really well to that. So, subungual hematomas, the name implies the hemorrhage underneath the nail. So the main question when it comes to subungual hematomas is when is it best to remove the nail, or does the nail need to be removed? Typically, we'll remove the nail if the nail plate is not firmly adhered to the nail bed, or if there's any type of traumatic involvement of the nail plate itself. Also, if there's an underlying fracture of the distal phalanx that's seen on X-ray, that's grounds to remove the nail itself, because you need to make sure that there isn't a nail bed laceration. If there is, then that's the potential for that's an open fracture, in which case the patient will need to go to the OR to have the wound irrigated and debrided. So it's very important to get X-rays, especially if there's any type of trauma that's been present to the nail after the visit. Hyperkeratonic lesions or hyperkeratosis. This is problematic, particularly in neuropathic patients. As I stated earlier, these particular lesions are precursors to ulcerations. And they have to be debrided on a routine basis in order to prevent ulceration. Also, it's important to accommodate patients with custom insoles and also custom shoes as well to reduce friction and the development of these particular lesions. These are just different corns and calluses that we commonly see in the foot and ankle. The helomomole, which is in between, is an invisible corn. Halomodurum, which is along the dorsolateral aspect of the fifth digit. The basic corn, which is associated with hammer-toe syndrome along the dorsum of your lesser digits. And then callus, which is along the plantar aspect, the high pressure area along the plantar aspect of the foot. One of the common questions that we ask residents once they come in, once they come here from medical school is, what's the difference between a corn and a callus? And a lot of times they kind of think about it and they're like, well, it's kind of the same thing, isn't it? The only difference is just the location. Corns are on the dorsum of the foot and the callus is on the plantar aspect of the foot. So. Metatarsalgia. This is a term that's basically used to describe non-specific pain in the forefoot, and it can be associated with many differentials. Atrophy of the fat pad along the forefoot, also sesamoiditis, inflammation of the sesamoids, which are located at the ball of the foot, any forefoot synovitis or bursitis, interdigital neuromas or nerve pain, the presence of a painful callus, any traumatic episodes of the forefoot, which can cause stress fractures, and any underlying arthritis as well. Verruca plantaris. This is a pathology that we see actually quite a bit here at the VA. Plantar warts are associated with a viral etiology, the human papillomavirus 1 and 2. And there are various ways of treating it. You can use cryotherapy, ethyl chloride, in order to freeze the lesion and then aggressively debride it. Some people use salicylic acid. Some people use various medications such as imiquimod. And usually, if the wart doesn't respond to any of that conservative treatment, then a simple surgical excision of the lesion itself is adequate in treating these. Cirrhosis or fissuring. This is particularly seen in the heel and it's seen a lot in diabetics because of the autonomic neuropathy. But it's a lack of hydration or lubrication, as well as diminished elasticity of the skin. This can be a potential for infection, particularly in immunocompromised patients such as diabetics. And this is usually treated with any type of urea-based lotion or cream. Silver nitrate can be used as well. And if the case is very severe, it's important to consider an occlusive application, placing the lotion or cream under a plastic wrap in order to make sure that it
lotions and creams, are they prescription only? Can
Um,
the patient get those over?
Some can be, they can get them over the counter. There are some higher ones such as ammonium lactate that can be prescribed, but most of them we can get them over the counter. So this is tinea pedis, athlete's foot. There are two different types. This is a very chronic case, but there are two different types. There's vesicular and interdigital, and it's all basically based on location, and a digital being between the digits, and anything else is considered vesicular. This can be a potential for infection if in a chronic state, but primarily this can be treated through antifungal therapy, fluconazole, ketoconazole, even Lamisil cream works very, very well in treating this particular pathology. This is actually a gerontological pathology that we see a lot here in San Antonio with this hydrotic eczema. A lot of times you'll have patients that come in that are hyperhidrotic, and the key presentation to it is that there are these clear vesicles that are on a non-erythematous base, and more often than not they're seen during the summer months. I can tell you I've seen a plethora of this during this past summer. But they can be treated with a topical steroid. Fluocinolone works very, very well in treating this particular skin lesion. Another common pathology that we'll see in the elderly population are macerated interspaces, and this can be due to three different components: either chronic tinea pedis, just an accumulation of moisture within the web spaces, or a bacterial infection known as erythrasma. So it's important to find out exactly what is the causation behind the pathology, and this can be done through a culture of the web space itself. So once you find that out, you'll know exactly how to treat it. Tinea pedis, you can treat it with an antifungal, or if it's simply a moisture situation. Placing lamb's wool between the toes can actually dry out the interspaces, and it should resolve on its own. And if there's a presence of erythrasma, erythromycin works very well in treating this. Venous stasis ulcers, again, something that we see quite a bit here in the VA. These are due to venous insufficiency, multiple varicosities, or valvular incompetence. They appear along the medial aspect of the leg and ankle, primarily along the area in which the greater saphenous vein runs. The main way of treating this are through pressure dressings and also reducing the edema, which can be performed through Uniboots. This is a particular kind of wrapping that has calamine lotion in it, so it soothes the skin, and then also it provides pressure in order to reduce the edema and allows the ulceration basically to heal on its own. This is a common pathology that we see up on the ward a lot, diffuse ulcerations. The main reasons or causations for this are immobility. More often than not, patients are diabetic and they have a decreased sensory perception, inactivity, being bedridden, and then having a previous history of pressure ulcers. So in order to treat this particular kind of ulcer, supportive care is needed, mainly offloading the area, which can be done with a Prevlon boot or a multi-polis boot, which can be ordered here. Those work very well. I think you probably have all seen them, they're like the big blue ski boots. They work well at offloading the posterior aspect of the heel. And more often than not, it's important to get a vascular surgery consultation just to assess the blood flow to make sure that the patient has enough optimal blood flow to heal this particular wound once the pressure is relieved. But the main thing is prevention, because once these ulcerations start, they're very, very difficult to treat. More often than not, patients may go on to what's called a partial calcanectomy, or they have to may have part of their heel bone removed in order to heal the ulcer, or it may even go on to a balloon amputation if it's severe enough. So some of the biomechanical changes that we see in the elderly patient. Again, you can see lengthening and widening of the foot, particularly due to progression of bunions and hammer toes. It's also very common to see atrophy of the fat pad or the supporting structures, collapse of the medial arch or pes planus subtype, and then the loss of skin elasticity as well. It's also very common to see digital contractures such as hammer toes or what are called claw toes or mallet toes. Again, bunions or hallux abductor valgus, hallux limitus and rigidus, flat foot or pes planus, a high arch foot known as pes cavus, and the presence of arthritis, again, any particular type, osteo, rheumatoid, psoriatic, presence of neuromas or interdigital nerve pain or nerve irritation, and then plantar fasciitis, which is actually is seen in the elderly, but it's also seen in younger patients as well. So some of the digital deformities that we commonly see are hammer toes. There are also what are called mallet toes and claw toes that are associated. For hammer toes, you'll see a contraction at the proximal interphalangeal joint here. For mallet toes, you'll see a contraction at the distal interphalangeal joint, and there won't be any pathology associated with the PIPJ. And for claw toes, you'll see a contraction both at the PIPJ and at the DIPJ. So more often than not, these patients will present with their toe completely curled and basically weight-bearing on the distal aspect. And a lot of times you'll see a huge hyperkeratotic lesion just because that particular area of the foot isn't meant to take up that much pressure during ambulation. So those are some of the more common visual deformities that we see in the elderly. There are a couple of ways to treat them conservatively. There's padding, there are different types of foam, tube foam, which works very well with the digits. If none of this suffices or this doesn't help at all with any of the painful symptoms, more often than not, these patients have to go on and have surgery or a hammer toe repair in order to straighten out the toe in order to relieve pain and pressure. So bunions or hallux valgus or hallux limitus or rigidus are also commonly seen, and they're pretty much treated the same way as hammer toes. They do have a genetic predisposition, so it's very common that if a patient that has a bunion, it's very common for their mother or their father to have a bunion as well. This can lead to metatarsalgia as well as the development of hyperkeratotic lesions, mainly along the medial eminence here, while patients are wearing shoes. So neuromas are resultant pain from irritation of the intermetatarsal nerves. What ends up happening over time in the elderly patient, they'll end up getting fat pad atrophy, which we talked about before. So a lot of the soft tissue structures start to dissipate. And so what ends up happening, your metatarsals end up becoming close together, and all of your interdigital nerves run between your metatarsals. So once these metatarsals start to migrate and become close together, you'll end up getting a pinched nerve or nerve irritation. Couple ways of treating them. We can be treated through corticosteroid injections to calm the nerve down and alleviate the inflammation around the nerve. Also custom orthotics with a metatarsal pad. You want the metatarsal pad mainly basically right behind the metatarsal heads in order to relieve the pressure, and what that does is that causes the metatarsals basically to splay out and take pressure off of the nerve itself. Physical therapy can be ordered, in which ultrasound therapy is very good at treating this particular kind of pathology. And if the patient isn't receptive to any of this, then surgical intervention or nerve decompression is another way of treating it as well. So these are just pictures of some of the various treatment forms, corticosteroid injections, padding. This is just a metatarsal pad. This could be incorporated into a custom orthotic, and then surgical excision or decompression of the nerve itself. So we often hear about flat feet in the elderly or pes planus foot types. These are some of the pathologies that are associated with it. Patients will present with a heel valgus. So as you can see here in this particular picture, you can see how the heel, the calcaneus everts once the patient is on and has a weight-bearing status. That's just a sign of heel valgus. Also, it's very common you'll see an abduction of the forefoot on the rear foot. In particular, this foot here, you can notice that you can see the fourth and fifth toes while the patient's weight-bearing. Well, that's not common, and that's just a key sign that there is forefoot abduction that's going on just due to the severity of their flat foot type. More often than not, you can see an association of what's called posterior tibial dysfunction. There's a tendon that runs along the medial aspect of the ankle that's known as your posterior tibial tendon, and it's responsible for keeping up your arch, the medial longitudinal arch of the foot. Over time, in elderly patients, this tendon will basically lose its function. You'll see a collapse of the arch itself. Again, bunions and hammer toes are commonly associated with flat feet, and this is defined as an overuse syndrome. The exact opposite of a pes planus foot is a high arch foot or a pes cavus foot type. It's very common to see calluses at the ball of the foot with this particular foot, particularly underneath the first metatarsal and fifth metatarsal. It's very common to see pad atrophy and migration. Claw toes are typically associated with this foot type, and you'll end up getting a heel there, so you get inversion of the heel as opposed to eversion of the heel. And this is a very, very rigid foot type. This particular foot type doesn't respond very well to a custom orthotic. So it's important to keep in mind the supportive shoe here because that's going to really provide more relief. Arthritis, just like anywhere in the body, the shoulders, knees, hips, it's very present in the lower extremity and the foot and ankle. Some of the common forms that we see are osteoarthritis, rheumatoid arthritis. This is actually a very good picture of a patient with rheumatoid arthritis. This is kind of what we call end-stage rheumatoid arthritis, and talking about a patient's forefoot, just because you can see that they have a very, very severe bunion. In fact, the hallux is dislocated at the first metatarsal phalangeal joint. And more often than not, we'll see patients that have rheumatoid arthritis that will present this way with a dislocation of the first MPJ and a superadductus of the second digit. Basically, the second digit is overriding the first. Gout is very common, particularly in the great toe. Can also be seen in the heel and also in the ankle to a lesser extent. And then the presence of psoriatic arthritis, which can result in heel spurs or heel pain. So with that leading into heel pain, this is a common lower extremity pathology seen in elderly as well as young people. At which time you get an irritation or injury to the origin of plantar fascia, which is along the medial aspect of the calcaneal tubercle. There are a lot of etiologies in regards to heel pain. The most common ones are plantar fasciitis, or inflammation of the plantar fascia at its insertion. And another one that we keep in mind is what's called Baxter's neuritis. Your medial calcaneal nerve runs in this area, and it's a branch off of your posterior tibial nerve. And more often than not, it's common to get a inflammation or a pinched nerve in that particular area. So some of the treatment forms for heel pain are corticosteroid injections, physical therapy, ultrasound therapy. If it's severe, if it's chronic, if it hasn't responded to any previous treatments, classic immobilization works very well, almost treating the foot as if it's fractured and getting the patient out of it and placing it in a cast, allowing everything, all the inflammation to calm down in the foot. and also shoe gear change, particularly for patients wearing ill-fitting shoes. Okay, there we go. So this is a slide just showing the different treatment forms for heel pain. You can use taping or foot strapping. This particular taping right here is known as a low-dye taping. A lot of times we'll do this and we'll have the patient leave it on for a week and come back, and then we'll ask them whether their foot felt better when it was taped or not. If it does, it kind of shows us that they'll respond really well to a custom orthotic. Stretching, physical therapy, corticosteroid injections, custom orthotics. If it's chronic and none of this has helped, then you can look at surgical intervention in the form of releasing the plantar fascia. However, this is very, very rare. More often than not, I would say 90 to 95% of this problem can be treated conservatively. So in regards to shoes, particularly in our elderly population, it's important to emphasize comfort versus cosmesis. Athletic shoes are very, very good. In particular, New Balance. There's a shoe type that's called Brooks. Merrells are very good shoes, and SAS are great as well. In our diabetic population, we stress use extra depth shoes and also custom molded shoes, because these reduce the amount of friction on the foot and limit the development of hyperkeratotic lesions and ulcerations. Also, custom insoles are vital as well, and some of the materials that we use for that are plastic or PPT. These cut down on friction as well.
What does the free time out refer to?
Oh, that's a particular shoe type.
Oh.
SAS. It's an SAS tennis shoe.
Oh.
There's one that's called free time. There's one that's called time out.
Oh.
So some of the over-the-counter shoe tips that we give our patients that are going to go shopping for shoes, it's important to make sure that your shoe has a soft upper and insole, and also it's important to make sure that there's at least a thumbnail's width between your longest toe and the tip of the shoe. This prevents any kind of nail pathology or sublingual hematomas. Also, it's important to realize or to note that when you bend the shoe, that it breaks at what we call the ball of the foot, right here. You don't want it to bend right in the center, because that's just a clear sign that there's a lack of support in the insole. So we'll often tell our patients to make sure that when you bend your shoe that it breaks at the ball of the foot. In addition, we also tell them to buy shoes at the end of the day, because that's generally when they've been on their feet the most and when they're the most swollen. So that way they get a pair of shoes that's more comfortable. So therefore, buying them early in the day and wearing them throughout the day, their feet will end up swelling and their shoes will become more painful. So what can patients do in between their visits with their care provider in order to prevent or cure some of these pathologies? Attending regular foot screenings is key, just staying on top of their appointments, and also education through diabetes awareness classes. The main thing also is self-care, just self-maintenance in between clinic visits, annual evaluation with their primary care physician or their foot doctor, control their diabetes, and also routine follow-up with their PCP. All of these are very, very vital, and things that the patients can do in order to ensure preservation of their limb.
What's the lesion on the right?
Oh, this is actually a very large verruca, believe it or not, plantar wart.
Wow.
So, some of the things that when we talk about our elderly population, we basically said that we're dealing with a time factor, which indicates transportation, isolation, mobility, and economic barriers. These are all things that we talked about previously. But keeping in mind that we're dealing with these rate-limiting factors and trying to work around them is going to provide us with the best particular care for this patient population. So So in conclusion, I'd just like to leave you with this quote from Thomas Fuller, who was a British historian, that is, "'Tis not knowing much, but what is useful that makes a man wise." So the more that we're able to self-educate our patients and make them aware of some of the things that can potentially happen, I think the better off we'll all be, and they'll be in the long run. So that pretty much concludes my lecture. I'd like to thank Mark Johnson for inviting me. It's really fun. I'm glad I had a chance to be here and share some of this with you guys today. And this is my email address here at the VA, so if you have any questions about anything foot and ankle wise or whatever, please feel free to shoot me an email, let me know. But I hope you guys enjoyed it and found it somewhat educational. So, does anyone have any questions?
Yeah.
Thank you very much.
Great.